It's a warm welcome to you. Welcome to this very interesting edition of Health Matters, reaching you live on NTA Channel 12 with you, your dependable station. Health Matters is a program we bring you up to date with health issues concerning you and what the Akwa Ibom State government is also doing to ensure that you stay healthy and fit. I remain your host, Umo Basilit. Today is a special edition because we have the #1 person in the health sector as far as the Akwa Ibom State is concerned, and I'm talking about no other person than the Honorable Commissioner for Health, Akwa Ibom State, Dr. Eken Emmanuel John. Hello, sir. Welcome to the program.
Thank you very much for having me.
Okay, sir. So, Dr. John, first of all, let's find out how has the journey been being the health commissioner since you assumed responsibility as the #1 person in the health sector?
I'd say interesting, very interesting, and quite challenging. So, in summary, the journey has been interesting and challenging.
Okay, and what are some of those programs that you reeled out so far?
Well, I'm not here to reel out programs of mine. There's only one person who was elected to lead the state, and that is His Excellency the Governor of Akwa Ibom, Pastor Mo Pasino, PhD. I think he's brought me on board to look at our developmental blueprint, which we call the ARISE agenda, and to interpret the health component of that blueprint. So we have somewhat like a Bible, our playbook from where we pick things and we implement. So everything you're seeing going on today within the health space is directly taken out from the ARISE agenda.
Okay, let's look at a key project that is being handled by your ministry. That's talking about the health insurance scheme. How does this work?
Well, it's something very fulfilling. Prior to the coming in of His Excellency Governor Moino, Akwa Ibom was one of the few states in the country that did not have a state health insurance scheme. So federal establishment workers had the NHIS running for them, and that was where it ended. At that time, the total insurance penetration in Akwa Ibom, health insurance penetration in Akwa Ibom, was less than 5,000 lives or thereabouts. And His Excellency came, and we have the Akwa Ibom State Health Insurance Scheme introduced sometime around October 2024. And between then and now, we've been able to move the needle, and we have currently around 2,000 lives enrolled into the state health insurance scheme. All civil servants with the Akwa Ibom State government fully covered, and we're making inroads into the informal sector, which is actually the most challenging aspect of implementing health insurance schemes in the country. So yes, we started just about a year plus ago, but we've gained some speed, not exactly as much as we would have wanted, but far better than many other states that started long before we came on board. And just last year, we gained national recognition as the fastest growing health insurance agency in the country. And so we're grateful. But talking about how it works, there are different categories. You have the basic package, where people subscribe for a fee, something we call the premium, and then after which they choose a hospital that they want for themselves and maybe their families, depending on their enrollment package, and they're given the insurance card. Whenever they take ill, they just visit the hospital, present the card, and everything from records, medical cards or files, as they call it, to medical consultations, laboratory investigations, and even the medications are all given free of cost.
So you talked about the basic package. So beyond that, which other?
No, I don't think that's a conversation we can have here, because they graduated. You may want an individual package, you're married, and that's fine. You want a family package, something that covers husband, wife, 4 children, that's also beautiful. You may also want a more advanced package, a premium package, where you would have to pay more so you enjoy more benefits. That's also possible. But the insurance agency has its office at Barracks Road, and people can walk in, make inquiries. They also have helplines that people can call in, make inquiries, and depending on what the person wants.
You talked about your interest in the informal sector. So for the meantime, is there any free Medicare services for other people outside the civil service?
Let me just say this, that everywhere in the world there is nothing like free medical services. And you say, this is a contradiction. Doctor, you used to organize free medical outreaches. What we call free is paid for by somebody.
Okay.
It is free to the benefiting community or persons, but it is actually paid for by the philanthropies, the government, or whoever is organizing that outreach. So for health insurance, it is pooled, it's a sort of pooled procurement. Now the thinking is that if you have a community of 5,000 persons, just think a little around everyday communal living. 5,000 persons, you can't have 500 persons sick at the same time. So you may have 67 persons out of 5,000 who are sick. Now, the others are also contributing, but at that point they are not ill. So when these people who are ill go to that place, their contribution may just be 15,000, 18,000, and their care may be 300,000. And you say, how can somebody pay 15,000 and is receiving care of 400,000 naira? The question is that the other persons who paid 15,000 and are not ill at that moment, their funds will buffer for this other group. So really that's how the concept works. And when one is enrolled, you can enjoy those services as free. Now, for the informal sector, we're already making inroads. We're talking to an educating Keke Drivers Association. We're talking and educating people from the mechanic village, artisans generally, because they are the ones who often run into the challenge of catastrophic health spend. Many of them may not have the best of education and so may not know better. You know, for you, you have the benefit of education. And when these things are explained to you, you understand, you subscribe, and then you're happy for some monies to be deducted from your salaries to make sure your family is covered. And many of these artisans are not even within the formal sector. So the question of deductions does not arise. You now need to spend time educating them and then overcoming several barriers, cultural barriers, religious barriers. So you just talk to someone about health insurance and they tell you, God forbid, you're praying for me to be sick, you are wishing me to have an accident, and then I just laugh. Because that same person that is asking you those questions, should he buy a car today? He will do car insurance. The difference is that if he does not do it, police will stop him on the road and harass him.
Yeah.
So maybe we need to embrace the culture that you have in Europe and America, where people are mandated by law to acquire health insurance. And when you do not have health insurance, it becomes an offense. Yeah.
Going back to the grassroots, let's look at the state of our primary health care centers. What's the position? There are a lot of concerns and across the different local government areas in our pipeline.
What concerns?
Do we have fully well-equipped primary healthcare centers that can readily meet up the demands
Do you
at that level?
do you have any country in the world where all their health facilities are fully equipped? And I'm throwing the challenge, whether it is in the Western world or it is anywhere in Africa. What we're doing, in fact, before now, we used to talk about primary healthcare center. It's the government of Pastor Moino that has now come to revitalize these health centers, and then we're building model health centers across the 31 local governments. So Akwa Ibomites are suddenly waking up to say, oh, you mean this can work? And many other communities are now calling out, oh, you've not reached my community. Please come to my community. We also have one that is not working. But they are awakening the consciousness that the first point of care within the health sector architecture is the primary health care, has been achieved and attained under the leadership of the current governor.
From primary health care now to the hospitals proper. A few months ago we had an incident where a patient, the video went viral, and the patient was lamenting, crying of how she lost the sister was crying loud, how she lost her patient when she took it.
People who commercialize and want to make profit from the unfortunate situation of their loved ones. There is no morality. As Honorable Commissioner, knowing what I know, I would not volunteer a discussion about that young lady. That would be me not dignifying myself. It was an unfortunate situation that happened. The government took decisive steps. Clearly a panel was set up, high-level panel, and the panel presented their findings. On the strength of that, I presented in ESCO to His Excellency the Governor. He gave directives. All of that has been implemented. But talking about the one who was crying, let her come out and cry again. Let's have a debate. And then I'll tell the world what I know. That somebody died in the hospital is not a measure of how well that hospital functions or not. I stand to be corrected. A lot of people who know nothing about healthcare assume that they are subject matter experts about healthcare. There is no hospital in the world where people do not die. We're not God. No one in the hospital tells you that every sick person who comes. Have you not seen in this your adult life, have you not seen Nigerians who traveled abroad for care on wheelchair and came back on wheelchair? They've been to Germany, they've been to India, they've been to US, and they don't have help. They are not able to be cured. In spite of their best efforts, their money is not able to buy them that. So we will do what we have to do as healthcare providers. Sometimes the hospitals will do their best and it still will not work out. There's a challenge that we have. Most of the people who go to these general hospitals, ask them when they present. Many of them present very late, quarter to die. And suddenly when they come to the hospital, they expect the doctors and the nurses to turn magicians. When they have spent the first 3 months of this ailment in their pastor's home, receiving prayers and other spiritual, and their pastors who claim to have spiritual powers did not perform miracles and magic. But they now come, and you see this thing, we're in the field, we don't bandy words with people. But what happens is, you find pregnant women, they go to traditional birth attendants. They have obstructed labor. The traditional birth attendant does not know what is obstructed labor. Cannot tell whether a pelvis is adequate or not. And continues to tell the woman to pump. And because even our pharmaceutical practices is poorly regulated, you find that these traditional birth attendants have access to oxytocin, misoprostol, and they now administer them to a woman in labor, which, why are you giving oxytocin? You want to augment contractions. But this woman is contracting fine. It's just that the passage is not okay for the baby to go out. But they don't have that knowledge, they cannot recognize. So they think erroneously that by increasing the contractions, and they have seen doctors and nurses use oxytocin, so they find a way to buy these things which ordinarily are prescription drugs. They buy them, store in their homes, and they store them poorly. They don't have even have refrigerators to store these medication, and then you give to the pregnant woman, and the uterus begins to contract. If you like, you can call it hypercontractions, right? And then once the uterus is hypercontracting, but there is no progress, the baby, the fetus, the baby is not descending and passing through the birth canal, the uterus becomes distressed, the muscles become weak, eventually you have rupture. And when these TBS now see that, they panic and send the woman to the hospital. The woman dies in the hospital, the family begins to make trouble. The doctors have killed my wife, doctors have killed my sister, and all of that. But you see, even though when these women present so late, and a doctor can recognize that this one is unlikely to survive, the training does not allow you to reject the woman. Where are you rejecting the woman to? The training insists that you should accept the woman and do your best within the circumstance to keep that woman alive. So when they tell this story, they tell it, and because by our profession, the MDCN does not allow us to bandy words with anybody. We just keep silent, and then we'll train to respect the memory of the dead. We keep silent, and then the family members, society begins to talk about our doctors are these, our doctors are that, and then what you have is what Chimamanda Adichie calls the danger of a single story.
Yeah, thank you so very much, Honorable Commissioner. And so, while not trying to highlight the woman in this case, I'm sure people might also want to find out what the outcome of that panel.
It was published. If you Google it, it was published.
You know, from you, it's just an opportunity to tell them.
Like those who were indicted were punished.
Okay.
And it was published everywhere.
Okay.
We have zero tolerance for negligence or professional misconduct from our staff. Just like we have zero tolerance for turning our hospital into theaters for content creation.
Thank you. So in case you're just joining us, the program remains Health Matters, reaching you live from NTA Channel 12, your dependable station. And today we have the Honorable Commissioner for Health, who has been talking so much about things that the Kwai State government is doing. You'll agree with me that they're doing a lot in the health sector. So just stay tuned, don't touch that dial. So moving on now, so we still want to remain with the state of our hospital. What are the facilities like and manpower?
Well, I'll take from the last statement, manpower. Globally, human resources for health is a problem. Last year, I secured approval from His Excellency for us to recruit 250 medical doctors. We couldn't find 100. Even after extending the application period for close to 6 months. So we had to shut down and continue with what we could find. So what we're now trying to do is to maximize the resources. And you say, oh, but pay them. Last year, November, His Excellency directed a 40% increase in the salaries of all health workers. 40%. That was even before the federal government now took a cue and revised the professional allowances for those in the teaching hospitals. And within the context of the Nigerian economy, also Akwa Ibom is trying. There's no state government paying as well as Akwa Ibom is paying, and even the federal government too. So when you juxtapose the fact that the government has incentivized healthcare professionals, we are still short. We're still short in numbers. And the reason is because it is not an Akwa Ibom problem. It's not even a Nigerian problem. It is a global problem. Just tune into your Google platform. You will see complaints about manpower shortages in the UK, in Germany, in US. In fact, America is now doing tax shifting. They are now trying to get physician assistants to do what physicians used to do. But we do not have that luxury. Because I mean, even with all the regulations in place, you see there's a lot of quackery. Then imagine trying to water down that, what is going to happen in Nigeria. So these are challenges that you would find. As we are now as a ministry, if you have someone who is a doctor licensed to practice, has completed NYSC, and you bring the person to us, we'll take the person. We're at that point. So it's a problem that we recognize. And we're doing, but recently His Excellency approved the injection of 2,854 healthcare professionals into the system. So we're documenting them, and they will also be posted. I believe that with the injection of those numbers, it will help our hospital security. But yes, we admit that there is a human resources for health challenge, and we're not happy about it, but it's not easily what we can do. What are our long-term goals? Activate our medical schools, train our own people. But you see, even if you start today, they are not going to graduate even with during Governor Moino's second tenure. So it's a problem.
Okay, so beyond that, Dr. John, what are the other healthcare system challenges that you have with the health sector?
Well, mine is not to complain about the challenges. I was brought in here to solve the problems, and problems we are solving. The biggest challenge really is that of manpower. You know, it's not the beautiful buildings that provide healthcare. They are just a part of the infrastructure for providing healthcare. It's not the high-end sophisticated equipment that provide healthcare. I'll give you an example. Here in Woman, you go to antenatal today. In some clinic, they are going to use what they call the sonicate, which is an electronic method of listening to the fetal heartbeat, right? But in many facilities, you still have what they call peanut stethoscope, which they will put on the ear and put on your abdomen, and they will still pick the same sound. One is sold around 150,000 to 2 million, depending on the brand. The other one is sold for between 2,000 naira and 10,000 naira. But they both work in the hands of skilled bed attendants. So it's not the sophisticated or non-sophisticated high-end equipment alone that is the problem. If you have those sophisticated equipment, it's a plus. And we have a lot of them. Just this January, His Excellency the Governor bought the latest model of CT scan, the 128-slide CT scan. When many governments, they do fanfare because they just commissioned 16 slides, 32 slides CT scans. Akwa Ibom State government is procuring several numbers of 128 slides. And in fact, our international hospital is going to be equipped with 256 slides and 128 slides. What we're looking at is precision medicine. But as much as we are investing in those, we recognize that those machines will lie waste and would mean nothing if we do not have the appropriate human resources for health to man them. So that's why it's important for us. I think the biggest challenge facing any health administrator in 2026 is the problem of human resources for health.
Okay, thank you so very much, the Honorable Commissioner Dr. Ikem John. And we have a lot. Unfortunately, time is not our friend, we have to leave. But before I let you go, we just heard about the resurgence of COVID in our sister state. So how prepared are you to tackle this?
Well, we're ready. Our epidemiology units have done training and retraining. We're activating our isolation center. But there's, bad news spread very fast, more than good news. Now you know that there was an outbreak, but you do not know that that has been sorted, that our sister states have declared that they are now COVID-19 free. You understand? So I urge our people that as you check your WhatsApp for news, check the internet, when the good one comes, also check and circulate it. But there is really nothing to panic for many reasons. One, in 2020, we weren't knowledgeable about COVID. It was a novel disease. In 2026, COVID is no longer a novel disease. We have so much within the literature about COVID. So once we see a patient presenting with symptoms, we'll be able to triage and know where each person falls into, and we'll be able to respond appropriately. So I don't think there's any cause for alarm.
Thank you so very much, sir. And that was Dr. Emmanuel John, the Honorable Commissioner for Health in Akwa Ibom State. It was amazing having you on our program. Thank you so much, sir.
Thank you. God bless you.
Thank you for staying tuned. Stay on to our other programs. Let's do it same time next week. I remain your host, Umo Basalit. Bye.